through big, big openings. Here's a valve separating the wall, the two chambers, and then here's the ventricle pumping out through the aorta to the rest of the body. On the other side, you have two big veins, which we'll talk about in a couple of lectures from now, pumping into the atrium, into the ventricle, and out to the lungs. And that picture is a little more realistic. And if we want to go a little further without bringing you a real heart, this is what it looks like with a very good artist rendering of the actual heart itself. Here's your thin-walled right side ventricle. Here's your thicker-walled left side. Here's a septum in the middle. This is called the intraventricular septum, and it separates the two sides. Here's the outflow from the right side. Here's the outflow going behind it through the aorta on the left side. And then here is the blood coming back in to the right, and they're showing you a picture of the valves. This is the valve that separates the left atrium from the left ventricle. I'm going to discuss those in a second. Here's the valve in the aorta. Here's the valve on the right side, and the valve on the pulmonary artery going back out to the lungs. There are openings between the two sides of the heart, which we won't get to great detail. Remember, when the baby is developing in the uterus, there is no oxygen circulating in the sense of air in the lungs. The lungs are collapsed. The baby has no access to air, gets all its oxygen from the mother's placenta. So the circulation is quite different, and actually there are holes in between the two atria that blood can get across, so circulation is complete. That closes shortly after birth. And occasionally that doesn't close, surgeon has to go in and sew it shut. And those are typically cardiac anomalies, which used to be very, very serious. Today with open heart surgery are virtually all correctable. Now, coming to the valves of the heart, this is another beautiful system that has evolved over many, many years. And the valves separate our four chambers. If we begin with this side, here is the left atrium, and there's a valve here called the mitral valve or the bicuspid. It just means it has two leaves. If you think of the way these valves work, they're kind of like parachutes. If you had parachutes pressed next to each other that were open and billowed out, you could force water or blood down between the parachutes and they would get out of the way. And then as soon as there was back pressure, they would come up if they were close enough and shut off backflow. They would have strings, too, to prevent them from flipping all the way up. And if you look, these valves have those strings on both sides. The mitral valve on the left side and the tricuspid valve on the right side, because it has three leaves. It would be like three parachutes. And these strings are called cordae tendineae, or tendinous cords. And they prevent the valve from billowing back and allowing blood to leak back into the upper chambers during the contraction phase of the ventricle. They also have little muscles down here called papillary muscles, which can tighten these strings as necessary. Those are the two valves that separate the upper chambers from the lower chambers. So when blood is rushing into the ventricle, the valves are open, and then when the ventricles squeeze on both sides, these valves shut to prevent backflow into the atrium, and these valves open up. Here's the aortic semilunar valve, meaning it has two half-moon shapes. And then the pulmonary valve also has half-moon shapes, and this one has three little cusps that you can see on this picture. Now, those valves don't have any cordae tendineae. They're in a much more constricted, tight, fibrous ring, and they don't need those cordae. They're just a different structure, but they do balloon, open and close, allowing blood to flow out and not allowing any to come back. So what can go wrong here? What kind of diseases can we get on the valves? The valves are very delicate. They look like fine, fine silk. And if you look at this picture of the valves, this is a pretty good drawing of what it would look like if you took it out. There's a fairly hard ring in the wall of the heart. And here's the parachute billowed back. So we have to presume that the blood during ventricular contraction can't go back into the atrium. but will go out the other end. Here's the tight chordae tendini and the papillary muscles, which are contracted to hold it tight. During the phase where blood is rushing into the ventricle, here the valve is open. This one is the bicuspid or mitral valve, and here are the chordae tendini, which are relaxed, and these papillary muscles are relaxed as well. What can go wrong with these valves? Well, one of the most common things that went wrong when I first went into medicine were patients who had had rheumatic fever. People who had strep infections, usually strep throat, and didn't get treated in the pre-antibiotic days, had a disease called rheumatic fever, which damaged the valves. Primarily, it damaged the aortic and the mitral valve, but it could damage all four. And it could damage other single valves as well. But primarily, this was mitral valve damage, aortic valve damage. The damage could happen two ways. One, it could make the valves too tight so they didn't open well. That's called stenosis. Or it could injure them so that they were irregular and they couldn't close very well, and that was called insufficiency. So instead of this valve, for example, closing, it would be irregular along its edges, scarred and nodular, and blood would leak back. That caused inefficiency. Part of the blood we were trying to pump out to the body was now leaking back into the atrium. And the heart would have to pump harder with more force and maybe more speed in order to get the blood out. Same thing could happen on the other side or in any other combinations. In the old days, much of our surgery was related to removing those valves, taking out the damaged valve, and actually sewing in what looked like a little wire basket with a ball that clicked back and forth as the valve opened and shut. You could actually sit in the room, in a quiet room, and hear the patient's valve opening and closing with a little click. Some patients actually told us it kept them awake at night sometimes. Today we have better valves that do this a little more silently, and more important, we've gotten rid of a lot of the rheumatic fever because we've been able to get the patients treated from their strep infections so we don't get rheumatic fever, and we hardly see this anymore except in the very old. There are other diseases such as mitral valve prolapse, in which this valve, the mitral valve, flops back and is slightly insufficient. It happens a lot in young women. It's often very asymptomatic. The patients are able to do exercise. They don't know they have it unless the doctor hears a murmur, and they get along perfectly well. It's only very few of them that have a problem with this. It needs to be treated. Next, we need to go and look at the supply of the blood vessel to the heart itself and see how the myocardium gets its own blood to feed the myocardium and the tremendous energy output that it requires. If you look at this slide, immediately after the blood exits the heart, the first vessels it encounters are these two vessels, the right and the left coronary arteries. Come right off the aorta, and they come right back to the heart. If you look here, it comes down along the wall of the heart, giving off branches as it goes. Another one goes around the back called a circumflex on the back side of the heart. And here on the right side, it goes down between the atrium and the ventricle, giving vessels to the atrium and the ventricle. And if you notice in the back, they seem to connect. Now, this again is evolution at its best. One thing you don't want is to run out of blood supply for your heart. You absolutely have to have it. Also, vessels run into the septum and all the other areas of the heart. This brings us to the first use of the term anastomosis. And anastomosis is the joining of sets of blood vessels or other hollow structures, but in this case, blood vessels. And the heart is just filled with anastomoses. As you can see here, this one, which is a major vessel called the anterior interventricular branch, will join up with a posterior branch. So if this gets blocked here, blood might be able to come across this side and help it out. Blood direction and flow can change as pressures dictate. Now, one of the most common causes of death is obstruction of one of these vessels. and that can